Hello, everyone. Welcome to Therapy Clips with Dr. O. I'm from the organization Human Service Consultants. And today we're going to discuss models of substance addictions. I'm going to first explain to you the moral model of substance addiction. In this model, religious institutions view AOD, which is alcohol or drugs, as sinful or a spiritual defect. It's viewed as a will violation of societal rules. Substance addiction, whether it's alcohol or any other type of addiction, this behavior infringes on others. And the viewpoint is that it should be a punishable crime. So anybody who's thinking from this particular model understands that alcoholism is a sin and heroin addiction is a crime. So the causal factor is a spirituality defect or a lack of personal responsibility. The implied intervention is that a person who has an alcohol or drug use disorder should be given spiritual direction, moral persuasion, or social sanctions. So these social sanctions come in the form of fines. It come in the form of incarceration, probation, and sometimes even parole. Now, who are the intervention agents? Clergy, any preacher, priest, any other type of religious figure in our community. Also, law enforcement agencies, like, for example, the police department, the judicial system, so the courts. These are your law enforcement agents. Now I'm going to talk to you a little bit about the next model, which is the temperance model. And it grew out of the temperance perspective. Now, the temperance movement arose in the late 19th century and lasted until the repeal of prohibition in 1933. It emphasized the moderation and the cautious use of alcohol. So alcohol was seen as a hazardous drug with the potential for inflicting harm. The temperance movement then grew into the prohibition movement. And the belief was that nobody could drink in moderation and abstinence was viewed as the only alternative. Then in 1919, the 18th Amendment to the Constitution proposed that the manufacturing, the sales, the transportation, and the importation of alcohol were criminal acts. Now, this law had to be repealed because the streets of our major cities were becoming bloody with the bootlegging and the fighting and the shooting that was being done by historical figures like Bugsy Malone and Al Capone. And so the law was repealed in 1933 by the 21st Amendment. So what is the causal factor? Alcohol. So the intervention is what did people do at that particular time and what do they still do today? Exhortation. They give strong warnings against alcohol use, but not only alcohol use, cigarette use. So when you look at your cigarette pack, you see a message from the Surgeon General that's telling you not to smoke cigarettes because it's going to cause cancer. Then that's also given a strong warning. And other things that they talk about is abstinence and prohibition. So you see the courts still will impose a fine if they catch you with certain substances. And also, as far as abstinence is concerned, then you still hear people talk about, well, you should just abstain from using that particular type of substance. Who's saying this? The abstainers. The abstainers are those people who are in recovery. They are no longer using substances, and so they try to pull other people along so that they won't use substances either. And also your legislators. They are intervention agents because they impose the laws. Like, for example, the bar must close at 2. Anybody under the age of 18 can't buy cigarettes. So those are some of the type of laws that are imposed on us. Now let's talk a little bit about the disease model. Now the disease model says that alcoholism and other addictions are seen as unique and progressive conditions or disease. It is the belief that the chemically dependent individual or someone with a substance use disorder is incapable of using alcohol or any other drug in moderation. The idea is that the disease is irreversible, that the person cannot be cured, that the disease can be arrested or a person can go into recovery if that person totally abstains from any addictive substance. Now, who is pushing the concept? People who are in Alcoholics Anonymous and Narcotics Anonymous. But also, everyone that's a clinician is also pushing the concept. So the idea is that there's an abnormality in the individual. Now, how did they come up with this concept that this individual is abnormal? They came up with the concept because the vast majority of the population in the United States, even though the numbers are high, but the vast majority are not using any type of substance in order to get through their day. So basically, what is being said here is that if there's a substance use disorder, then there's something going on that's abnormal about the individual. This is just a perspective from one type of model. So what does the interventions look like? It looks like an identification and confrontation of that particular individual. First, we identify that this person have a substance use disorder. If they don't go into treatment, we try to confront them and get them into treatment. And the belief is abstinence is lifelong. So who are the intervention agents? Your recovering alcoholics or anybody that's recovering. Doesn't necessarily have to be an alcoholic. It could be anybody. And people who give peer support. Now, another type of model is the education model. It's the belief that problems evolve because of knowledge deficits and the lack of accurate information. So the whole idea is that if you educate people about what drugs can do to their body, then they will either stop or moderate their drug use. And this is done in lecture and educational type of formats like this video presentation, like brochures, like fact sheets that you may find on the internet. Okay, the whole idea is that with appropriate and effective information about the hazards or risks of chemical substances, the individual will moderate or stop the AOD use. So the causal factor is the belief that there's a lack of knowledge and that there's a lack of motivation to abstain from substance use. The intervention is education. Your intervention agents are educators. Now I'm going to take you into a different type of model. This is the characterological or personality model. Now, it also views AOD use as abnormal and that the person has some type of abnormality that's going on. Now, this concept of addictive personality is no more. We in the field do not look at individuals as if they have an addictive personality. Instead, we look at individuals who have a substance use disorder as people who have certain behavioral type of traits that may lead them to using substances and eventually becoming addicted to these substances. We believe that that person may have inadequate defenses like coping skills for resolving the problems that they encounter in their lives. And they are unable to restructure their own personality. Now, this whole idea of these behavioral traits that's associated with AOD use fall in the categories of low self-esteem, sex role conflicts, difficulty in coping with stress, problems and frustration tolerance, passive dependent patterns of behavior, egocentricity with demanding and manipulative behaviors, a drive for power and control by those who feel powerless. So the causal factors are personality traits or dispositions, inadequate defenses, difficulty in impulse control, antisocial personality, problems with frustration tolerance, manipulative and demanding behavior, and a lack of power. So the intervention would be psychotherapy, talk therapy with a therapist, social worker, and addiction counselor, psychiatrist, whoever is doing the work with you. Risk identification, understanding who have the disorder, trying to get them into treatment, self-image or self-concept modification, enhancing self-esteem, interpersonal skills, focusing on impulse control, because if the urge comes, some people will move on the urge before they think about the consequence. Alternative responses to frustration. So what do you do when you become frustrated? Well, deep breathing, taking a walk, exercise, are all the alternatives to reducing the frustration and improving self-defense. So that's giving the armor of coping skills to deal with any issue that may emerge. Also, dependency reduction. Who's doing this work? Psychotherapists, social workers, and counselors. Now we're going to talk about a different model. This is the conditioning perspective. In this particular model, what you will learn is that behavior is learned. Behavior is learned. And so it's the speculation that learning and conditioning lie at the heart of AOD problems. So it's the belief that AOD use is a learned habit. And some of these principles that have been learned can be unlearned, and these habits that have been learned can be unlearned. So what type of perspectives are we coming from? We're looking at the classical conditioning and the operant conditioning perspectives. Now, with classical conditioning, focus on triggers. It's just like if you had a drug dealer, he drove a white Mercedes-Benz, you bought drugs while he was in his white Mercedes-Benz. Every time you see a white Mercedes-Benz, you're going to think about drug use. That is classical conditioning. That is a trigger. When you think about operant conditioning, think about reinforcement. Reinforcement is whatever felt good to us, we're going to do it again. If it tastes good, we're going to taste it again. If it feels good, we're going to do it again. So the causal factor is a conditioned response. Now that conditioned response is once again that habit that you form. The reinforcement is it made me feel good and I liked it. So what happens in interventions, we counter condition and you relearn. So who's doing this work? Your behavioral therapist or other professionals trained in behavioral modification techniques. Now look at the biomedical perspective. In this perspective, in this particular model, what they're saying is that at the heart of AOD use is genetics. So someone in the family. So whenever we're doing your biopsychosocial, we ask you about family history. And this is the reason we're trying to track to see whether or not someone in the family also have AOD use. So we do things, your researchers will do things like people like who work at Johns Hopkins. When you go into those studies with them, they're your researchers. They may use adoption studies, twin studies, or genetic marker studies. And the focus is on heredity, the brain, and biochemistry. The causal factor is a genetic endowment. So there's a genetic predisposition that if you take a first drink, then that first drink is going to lead you to drink other drinks and then eventually develop alcoholism. And also the physiological aspects of the person's body may cause them to become addicted to drugs or alcohol. So the intervention is identifying those people who are more at risk. So if you grew up in a family with alcoholics, people who have an alcohol disorder, you always have to try to think, is this going to happen to me, my child, or anybody else in the family? And then, of course, there's medical treatment that's available. Who's doing this work? Physicians, social workers, and other licensed clinicians. Now, from the social, cultural, and psychological model, the focus is on the individual and the culture, religion, family, peer variables, and psychological factors that person is connected to. So the environment and culture contributes to drug addiction and alcoholism. Family environmental patterns predispose children to alcoholism. A family history of criminality or antisocial behavior, family management problems, parental drug use and positive attitudes towards drug use, and friends who use drugs are all predictors of adolescent AOD problems. So, the psychological model gives an explanation of why addiction exists. Alcohol and drug use is secondary to the other problems in the person's life. So the person is using this AOD, alcohol or drugs, to assuage the emotional pain experienced by that person. So that's from the psychological perspective, that the person have other problems, and in order to get rid of these problems for a while, I'm going to self-medicate. I'm going to use my drug of choice. So the social learning model focuses on a category of bad habits, such as drinking, gambling, smoking, overeating, that result in addictive behavior. So the AOD use is initiated by environmental stressors or by looking at some type of model in the community or in the household and wanting to imitate that particular model. And you all see it when you walk into a liquor store and the female, she's in an evening gown and she's holding that Hennessy. And she's saying that Hennessy is such a good time until you can identify with that model because you want to have a good time. And if you are female, you want to look as pretty as that female that's on that poster. Okay? So it's the recognition from models that there's a perceived status that's associated with the AOD use. That's the end of our presentation. I'd like to thank you for spending time with me. This is Dr. O from Human Service Consultants. Have a blessed evening because I am preparing this tonight for tomorrow. And what are you supposed to do? Love always. Be safe. Be blessed. All that good stuff.